So my name is Jonas. I'm an associate professor in the operations management group. I've taught OM, uh, introduction to operations management in the MBA program, as well as a healthcare elective across programs. And my research is partly, or like a big chunk of my research is in global health. So I'll talk a little bit about that and why I think it's an interesting kind of field to be in. And then I'll give an example of something we did. And I should say, just like Karen, I've had a bunch of MBAn RAs in the past, and they, without exception, been fantastic. I've had a really, really, really good experience working with MBAn students on all of the things that Karen said. And they've often been very kind of heavily involved in the sort of scoping and an early stage idea generation, which has been fantastic. So I work in healthcare, like I said, and I think I've done work on sort of global health, on ambulance systems, on public health. And so I think what makes my profile a little bit different from other people who work in health is that I haven't been doing any hospital operations. So I've been interested in these sort of higher level systems that contribute to health outside of the buildings of hospitals and clinics and so on. And I think another thing that's maybe a little bit unique is all of this effort on global health. So global health meaning sort of not the medicine, not the technology, but like the operational and system design of the systems we use to deliver health in very, very resource limited settings. So these are settings that are so resource constrained. For example, in sub-Saharan Africa, like Karen mentioned, that their systems just look fundamentally different from what we're used to, at least in the US and in the UK, where I was before. And so they require kind of a different way of thinking, different set of tools. And so they make for very interesting problems. So let me talk a little bit about why I like this as an area and then give an example. I think I can be pretty quick, but we'll see. So I like working on this because I think there's potential for impact. Just like Karen said, I think we're all interested in having some impact on the ground. And if you just look at basic statistics, there's a lot of work to be done, for example, in sub-Saharan Africa. Like we're talking about high prevalence of preventable death, which is by definition preventable because we know how to deal with it clinically and technologically. We just haven't put the proper systems in place. The next reason is, for that reason, because it's a systems problem, there's like an operational bottleneck. Operations research, operations management, analytics are the right tools to deal with it, right? So it's not about fundamental biology or medicine. It's really about systems. And so I think the expertise that we have in operations and analytics is actually the right toolkit to now make a difference. Like I said before, these systems are very different from what we've been doing. Like our field has been doing hospital operations for probably 20, 25 years. But it's not as if the insights from those types of analysis would transfer directly to sub-Saharan Africa, just because the infrastructure, the systems, the challenges, everything is different. Even the kind of priorities in terms of which clinical conditions we look at is different. And so we need to do kind of fundamental systems research to be able to address big questions in this field. And finally, and this is relevant for an analytics crowd, another thing that's happened is with the Clinton Foundation, the Gates Foundation, and these types of institutions becoming involved with global health delivery on the ground, is that now we have access to data that before we did not have, right? So it was very different. I was too young at the time, but I think it was very different 30 years ago trying to make an impact on the field in global health because you didn't have sort of routine operational data being collected. Now we do have some of that. And so we can actually use analytics to try to make a difference. Okay. This is really the key thing. So if people have questions about this, I'd love to talk about this. But I'll also give an example of a project that I think kind of fits, at least to some extent, all of these. So the background is AIDS, HIV/AIDS, right? As you probably know, the prevalence of AIDS is predominantly focused on sub-Saharan Africa. So it's a big challenge. And the global community has made a ton of progress in terms of diagnosing AIDS, right? So we get people diagnosed and get them on treatment. The interesting thing is then the focus of public health shifts kind of, I guess, up or downstream in the cascade, in the sense that it's not enough to get people on treatment. You need to make sure the treatment is working and that they're adhering to it, right? And so the goals now are these 90% of people being aware of their status, 90% of those being on treatment, and then 90% of those having suppressed viral load. And we're nowhere near these targets, okay? And what you need to make sure that the person who's on antiretroviral therapy for HIV is that the virus is suppressed is PCR testing. And a few years ago, nobody knew about PCR, but now everyone does. And so this requires sort of heavy-duty lab equipment. Okay, and in, for example, Malawi, the country we were working with, you have hundreds and hundreds of clinics out in the communities, some of them very rural, but only about 10 molecular labs that have the capacity to do this testing. Okay, and so what you need to do is to collect samples, blood samples from people out in the field, transport them to a district hub and then to a lab, and then the results back to the field so that they can be communicated with the patients. So it's an example where clearly the operational system that's in place has a lot to do with how effectively we can, try to achieve these goals that I said before. We work with an NGO called Riders for Health, which is sort of operates these motorcycle couriers who do this transportation. They go collect samples, bring them to the district and then to the lab, then pick up results and bring them back to the clinic. And when we started engaging with them, we realized that basically what they were doing is they were doing sort of these fixed postman routes. So the couriers would do the same schedule every week. Okay, this was just a way to kind of guarantee a certain service level when they negotiated with the Ministry of Health to set this up. The issue with this is that there was a very, very high proportion of empty trips. Like they would be visiting places, driving for hours, and not having any samples to pick up or any results to return. And on top of that, because they were doing this sort of inefficient scheduling, they were contributing to delays. And so, which is bad for patients, obviously. And so we kind of thought of this somewhat simple system, but it doesn't have any precedence in sort of global health, which was let's design some sort of communication system that allows people in the field to communicate to us, the NGO, whether or not there are samples to be picked up. And it's not obvious how to do this, right? Because it might not be electricity, there's no managerial infrastructure, and so on, okay? And we didn't want to deploy new technology because then we have to maintain it, and we didn't want to put valuable sort of new technology in the field in case it doesn't stay there very long. So we had to convince health workers to use their own technology, their own phones to communicate with us, okay? The second part was, even if you have all this information, it's not obvious what to do, right? On nationwide, even if you know where there are samples, it's not an easy thing to do to route and schedule courier trips to make sure that you have the most kind of efficient system possible. And so that's where optimization came in. And so the idea was, we'll sort of crowdsource the data from the health workers. They'll use their own phones to tell us whether or not there are samples to get picked up. And then we'll use optimization to schedule and route couriers on a day-to-day basis. So it will be much, much more dynamic than the old kind of postman system that was in place before. 3 minutes, okay? So let me just do this very, very quickly. So the system for crowdsourcing the data was this sort of USSD system that was free of charge to all of the health workers in the country. And we only asked them at the end of the day, enter the system, use the code that corresponds to your facility and tell us how many samples are waiting. Okay, so ideally, very little disruption to the day. All they needed was to have their phone charged, and we'd already checked that most of them have phones. So that was sort of the main part of the information system. I'll skip very quickly through the transportation optimization. It's basically about using this information and then predicting the samples that will be coming in the next week. And based on this information, try to come up with a smart schedule and routes for the couriers to pick up samples and deliver results. And then the interesting thing was, well, we were able to implement this. So we implemented in these 3 districts that were meant to be kind of representative of the scope and scale of the different, or the characteristics of the different districts in the country. I'll go very quickly through the results, but what I'm proudest of is we did this in 3 districts, then completely handed off to the field. So the NGO in country now owns the system. And since then, this has been scaled up and is now running in 11 districts. And the Ministry of Health and the CDC in the US, who's the main funder of this, have committed funds and have like a timeline for scaling this up nationally. So the hope is that, you know, in a couple of years, the system we designed, kind of doing desk research at MIT, will be used to route and sort of crowdsource data all through the country to try to make HIV diagnosis and viral load monitoring more efficient. I'll do maybe one set of results. So the first thing is we actually got data from health workers. The second thing is the data was reasonably accurate. So this was an empirical question. We didn't know if this was going to happen. Using this data, we were able to shorten the delays associated with transportation, and we were basically able to eliminate these empty trips. This is obviously useful for operations, but it turned out to be really, really, really valuable for the NGO in country as well, because they were losing credibility because people saw them as wasteful because they had these empty trips. And then using, you know, this IT system and then analytics, we were able to kind of help their status in country as well to sort of come across as a professional partner to the Ministry of Health.